Welcome to an important review of menopausal hormone therapy, or MHT, and its impact on cardiovascular outcomes. Let's start with an introduction to combined MHT. Combined MHT is primarily indicated for relieving moderate to severe menopausal symptoms, not for preventing cardiovascular disease. However, combined MHT, especially oral CEE plus MPA, is linked to an increased risk of stroke and venous thromboembolism, although this risk is low in younger, recently menopausal women. Next, let's look at how the duration and timing of MHT use can affect cardiovascular risk. Cardiovascular outcomes are significantly influenced by how long MHT is used and when it started relative to menopause onset. The quote, timing hypothesis suggests that starting MHT closer to menopause is safer, while delayed or prolonged use, especially in women over 60 to 70, increases cardiovascular risks. Now let's consider the influence of estrogen formulation and the route of administration. Transdermal estrogen shows a lower risk of VTE and stroke compared to oral estrogen. Oral CEE/MPA regimens carry the highest risk for cardiovascular adverse events, making transdermal options generally safer for women at higher risk. Let's explore the role of progestogen type in cardiovascular outcomes. Synthetic progestins like MPA and tibolone are associated with increased CVD risks, whereas micronized progesterone and dydrogesterone have a more favorable cardiovascular profile. Therefore, the choice of progestogen should be personalized, favoring micronized progesterone or dydrogesterone for women with higher cardiovascular risk. Now let's address the existing evidence gaps and limitations. There's a significant lack of long-term randomized controlled trial data for newer, lower-dose MHT formulations, transdermal routes, and micronized progesterone. Most of our current understanding comes from observational studies. We urgently need direct, randomized controlled trials comparing different estrogen and progestogen types to solidify our guidelines. In conclusion, let's summarize the key takeaways. To summarize, cardiovascular outcomes with MHT are affected by duration and timing. Transdermal estrogen and micronized progesterone or dydrogesterone are generally preferred to minimize cardiovascular risk. Individualized risk assessment and shared decision-making are crucial for guiding MHT therapy selection and duration, ensuring the best outcomes for each patient.